Hi, great to see you again. I'm Dr. Chengzi the Orange. In our last video, we explored the treatment of depressive disorders through psychotherapy. Today, we'll focus on antidepressant medications, electroconvulsive therapy, ECT, and several other therapeutic methods. When are antidepressants needed? Psychotherapy is a valuable treatment for depression, but its effectiveness depends on the severity of the condition. Based on PHQ-9 scoring, psychological therapy alone is often sufficient for mild depression, PHQ-9 score less than 10. However, for moderate to severe cases, PHQ-9 above 10 or even above 20, antidepressant medications should be considered either alone or in combination with psychotherapy to improve outcomes. As of December 2024, the U.S. Food and Drug Administration, FDA, has approved over 25 antidepressants. In our previous discussion, we highlighted 3 key neurotransmitters that regulate our mood and cognition. Serotonin, the feel-good neurotransmitter; norepinephrine, the energizing chemical; and dopamine, the reward and motivation driver. Most antidepressants work by enhancing the availability of these neurotransmitters. Based on their mechanisms of action, antidepressants are categorized into 5 main types. 1. Selective serotonin reuptake inhibitors, SSRIs. How do they work? Imagine the serotonin transporter in the synapses as a drain that normally allows serotonin to flow away for recycling. SSRIs act like a partial plug, slowing down this drainage and allowing serotonin to stay in the synapse longer, where it continues to support mood regulation. 2. Serotonin norepinephrine reuptake inhibitors, SNRIs. How are they different from SSRIs? SNRIs block the recycling centers for both serotonin and norepinephrine, increasing the availability of both neurotransmitters in the synapse. This provides a dual effect, improving mood while also boosting energy and focus. 3. Atypical antidepressants. Unlike traditional antidepressants, atypical antidepressants work through unique mechanisms, targeting different receptors to relieve depressive symptoms in diverse ways. 4. Tricyclic antidepressants, TCAs. They function similarly to SNRIs by increasing serotonin and norepinephrine levels, but they also affect multiple other receptors, including histamine receptors and causing sedation, alpha-1 adrenergic receptors and leading to dizziness and low blood pressure, and muscarinic receptors and causing dry mouth, constipation, and blurred vision. If SNRIs are like a modern precision-guided missile targeting serotonin and norepinephrine, TCAs are like an old-school bomb, effective but with more collateral damage, side effects. 5. Monoamine oxidase inhibitors, MAOIs. They are among the most powerful and riskiest antidepressants. Think of monoamine oxidase, a MAO, as a Pac-Man eating up extra serotonin, norepinephrine, and dopamine in the brain. MAOIs block this Pac-Man, causing neurotransmitter levels to rise, which can improve mood but also lead to dangerous side effects. MAOIs have strong drug interactions and require strict dietary restrictions to avoid severe reactions. Because of these risks, they are rarely used today unless other treatments fail. Then, what are the most commonly prescribed antidepressants? Based on global clinical trials and prescribing trends over the past 15 years, 15 antidepressants are recognized as first lines. The most commonly prescribed among them are highlighted in red. I have to apologize because what I am showing is extremely boring. Table full of drug names, indications, and side effects, none of which will spark joy or light up your brain or make you suddenly feel smarter. But think of it as a cheat sheet. No one is grading you now. But one day when you actually need this information, you won't have to search the whole world for answers. Just come back to this video, you'll have the answer in seconds. Is there a best antidepressant for all patients? The short answer is no, because every patient responds differently. While most antidepressants are similarly effective, they can vary widely in side effects and how well people tolerate them. Many patients stop taking antidepressants because of unwanted side effects. Among the available options, citalopram, escitalopram, fluoxetine, sertraline, and vortioxetine tend to be better tolerated, meaning fewer people discontinue them due to side effects. Of these, escitalopram and sertraline stand out in the US as being among the best for both effectiveness and tolerability. Then how can you tell if an antidepressant is working? The first improvements usually appear within 1-2 weeks, with better sleep, better appetite, and reduced anxiety. By 2-4 weeks, patients may experience noticeable better mood, improved focus, and overall emotional well-beings. However, deeper symptoms, such as feelings of worthlessness or profound sadness, may take longer to fully resolve. It is important to note that while antidepressants perform significantly better than placebos, their efficacy is generally mild to moderate. There are some key facts to know before starting therapy. 1. Which to choose, psychotherapy or antidepressants? The answer is it doesn't matter depending on what you like better. Psychotherapy and antidepressant medication are nearly equally effective in treating depression. 2. Combination and adjusting treatment. Combining antidepressants with psychotherapy is more effective than using either treatment alone. So if psychotherapy alone does not provide sufficient results, clinicians may add antidepressants. If the initial antidepressant is ineffective, clinicians may switch to another or introduce a second medication. 3. Limited response. Approximately 10 to 30% of patients with major depressive disorder, MDD, do not respond to either antidepressants or psychotherapy or a combination of both. This condition is often referred to as treatment-resistant depression, TRD. 4. Serious warning. Antidepressants help reduce suicidal thoughts along with other depression symptoms, but in some cases, they can trigger new suicidal thoughts or behaviors, especially in the first few weeks of treatment. This happens because a person may still feel depressed, but regain enough energy to act on troubling thoughts. If you or someone you know experiences worsening depression, new suicidal thoughts, or unusual behavior changes, contact a doctor immediately. Early support can make a big difference. After covering antidepressants, it's time to discuss electroconvulsive therapy, ECT. When you hear ECT, you might imagine scenes from old horror movies. People strapped down, convulsing under electric shocks like Frankenstein. That's Hollywood, not reality. While ECT has been around for over 80 years and was once a crude treatment with severe side effects, modern ECT is a completely different story. In clinical practice, it ranks as the third most commonly used treatment for depression, following psychotherapy and antidepressants. It is one of the most effective options for severe depression, particularly when antidepressants fail. Suicidal thoughts are extreme. Psychotic depression is present. Bipolar depression requires urgent intervention, or when pregnant or postpartum women need treatment but cannot take medication. The procedure itself is relatively simple. The patient is placed under anesthesia, and a controlled electrical impulse is delivered to the brain for a few seconds, inducing a mild seizure that helps reset brain chemistry. The entire process takes only 5-10 minutes, and patients wake up shortly after. Modern ECT is generally safe and well tolerated, though it can cause temporary side effects such as mild memory loss, confusion, headaches, muscle soreness, nausea, and fatigue. Fortunately, these symptoms are typically short-lived and manageable for most patients. If a patient is fearful of electroshock therapy or unwilling to undergo anesthesia, they have a milder, non-invasive alternative: transcranial magnetic stimulation, TMS. Although TMS has been studied for about 40 years, it was only FDA approved for depression treatment in 2008. TMS works by using rapidly changing magnetic fields to induce electrical currents in targeted brain regions, helping to regulate mood. The procedure is straightforward and comfortable. The patient sits in a chair while fully awake, and a TMS coil is positioned over a specific scalp area to deliver repetitive magnetic pulses. Each session lasts 20-40 minutes, typically 5 days a week for 4-6 weeks. Since no anesthesia is required, patients can immediately return to their daily activities. Compared to other treatment methods, TMS has minimal side effects, making it an appealing option for those who cannot tolerate medication or ECT. However, TMS is not as widely used as ECT due to factors such as lower response rates, longer treatment duration, limited availability, and more restricted insurance coverage. Well, here is an interesting fact about TMS. If you are struggling to quit smoking, TMS is FDA-approved method to help people break nicotine addiction. Now let's talk about esketamine-ketamine therapy. It's no exaggeration to say that esketamine and ketamine are considered game changers in depression therapy by some clinicians. Why? Because they can lift depression in a matter of hours, whereas traditional antidepressants take weeks to show results. This rapid effect has sparked immense interest, especially after Elon Musk publicly admitted to using ketamine once every other week. Ketamine is not new. It has been widely used in anesthesia for over 50 years. Despite its long-standing medical history, the FDA has never approved ketamine for depression, largely due to concerns over its hallucinogenic effects, potential for misuse, and lack of long-term safety data. To address these issues, esketamine, Spravato, was developed as a more potent and refined version of ketamine with less side effects. The FDA approved esketamine in 2019 for treatment-resistant depression, TRD, and expanded its approval in 2020 for major depression with suicidal ideation. What makes it even more appealing is its ease of use. Just 2 nasal sprays, followed by a 2-hour monitoring period with a clinician. Unlike IV ketamine infusions, esketamine is covered by many insurance plans, including Medicare. However, esketamine still shares ketamine's dissociative and hallucinogenic effects at higher doses, which means both treatments require strict medical supervision. While early results are promising, long-term data on safety and efficacy are still needed before these treatments can gain widespread public trust and become mainstream in depression care. The talk is already too long, I know, but how can I possibly end it without showing the power of AI? On March 30th, 2024, the US FDA approved Rejoin, a digital therapeutic smartphone app for treating major depressive disorder in adults aged 22 and older. Rejoin is not meant to replace traditional treatments like antidepressants or psychotherapy, but rather to complement them. It uses cognitive behavioral therapy-based exercises and timed notifications to encourage patients to stay engaged with their treatment plan. Rejoin is only available by prescription. So after all the discussion about medications, brain stimulation, nasal sprays, and even a bit of Elon Musk, it turns out that your phone might be part of your depression treatment. Next time, we're diving into something even more complex, where science, ethics, and life itself collide. Any guesses? Stay tuned.